everyone, and welcome to SUPTA's talk on ear pain. Today I am joined by, would you like to introduce yourself?
Hi, good afternoon everybody. My name is Lukman. I'm a fourth year medical student from St. George's.
And today, Lukman will be going through ear pain. To make this session as engaging as possible, just as normal, we have these polls which you can answer throughout the presentation. And we'll give you guys a feedback form at the end, which if you complete, you'll get your certificate of attendance and exclusive discount codes for Teach Me Surgery and pass the MRCS. I'll talk about this a bit more later, but we've also got an exclusive question bank and other resources available on our learning portal. So be sure to check out our website and follow our social media to access them. And finally, before we begin, we'd like to thank our partners, Royal College of Surgeons, Geeky Medics, MDU, More Than Skin Deep, Medall, Teach Me Surgery, and Pass the MRCS. And without further ado, I'll hand over to Lukman.
Okay, amazing. Thank you very much for that, Bianca. So like she said, we'll be talking about ear pain. I'll just go over to the learning objectives. So I've kind of broken down this presentation into a few broad topics. So firstly, we'll look at the anatomy of the ear, the outer, middle, and inner ear, and also the salivary glands. We'll also look at the muscles of mastication and facial expression, looking at the innervation. We'll focus on some of the main nerves that we need to know about, such as the trigeminal nerve and facial nerve. And lastly, we'll be looking at the common ear pathologies that we are likely to experience in clinical practice and how you can manage those, looking both medically and surgically. Throughout this talk, I kind of just want you to gain an understanding that many of these structures are interconnected and relate to each other, and through various different paths, such as neurological and also physical connections. And so just kind of tune your brain into the fact that there are many connections that we're unaware about. And if you're able to do that, then you should do really well. So firstly, we'll just look at the anatomy of the external ear. So we divide the external ear into two parts. So we have the auricle, also known as the pinea, and the external acoustic meatus. So the auricle is a paired structure. That's the bit that we can see on the side of everybody's heads. It functions to capture and direct sound towards the external acoustic meatus. It's mostly cartilaginous structure, the only exception to that being the lobule, which is the red part at the bottom. That's the only part not supported by cartilage. The cartilaginous part of the auricle forms an outer curvature, which you can see there. That's the helix. And there's an innermost curvature as well, which is in parallel with the helix, called the antihelix. The antihelix then divides into two separate portions as well. We call these cura. So we have our inferior anterior crus and also the superior posterior crus. Carrying on more medially, we have a hollow depression that we call the concha. This is continuous with the external acoustic meatus, and that just directs sound into the meatus. And then immediately anterior to the beginning of the meatus is an elevation of cartilage, which we call the tragus, and opposite to that is our antitragus. Amazing. So we'll go into the external acoustic meatus now, also known as the external auditory canal or the ear canal. And it's an S-shaped tube which is situated within the tympanic portion of the temporal bone. Its entrance lies just in front of the mastoid process of the temporal bone. And in adults, it's usually around 2 to 3 centimeters long. So it's not too long. And the end point of this is the tympanic membrane, also known as the eardrum. So it's quite a thin, funnel-like tube. And its primary function is to channel sound waves into the tympanic membrane. But it also serves as a protective function as well, but we'll go into that a bit later. So the lateral third of the external acoustic meatus consists of cartilage, and it's covered with skin, which extends from the auricle, while the medial 2/3 is formed by a bony tunnel, which is covered with a thin layer of skin continuous with the external surface of the eardrum. It has quite a narrow opening, which prevents large objects from entering the canal and damaging the tympanic membrane. Within the canal itself, there's subcutaneous tissue within specifically the cartilaginous part, so the lateral third, and it has modified sweat glands known as ceruminous glands, which produce earwax, also called cerumen. Okay, so cerumen, along with the small hair cells, lines the canal, and that prevents small objects, small particles, things like insects, from entering into the eardrum and causing damage. Okay. Additionally, it also moisturizes the canal and the eardrum, and it contains an enzyme called lysozyme, and this is capable of breaking down the cell walls of bacteria. So any inline bacteria there should hopefully be destroyed by that lysozyme. Going more medially now, we're now in our middle ear. So the middle ear is a air-filled chamber within the temporal bone known as the tympanic cavity, and it's located between the external and internal parts of the ear. And it's usually divided into two parts. So we have our tympanic cavity, which contains our ossicles, so the malleus, incus, and stapes. So those are just really tiny bones that vibrate along with the tympanic membrane and transfer that sound into the cochlea. And then we also have our epitympanic recess. And in terms of its boundaries, it's bounded laterally by the tympanic membrane, medially by the lateral wall of the internal ear. The roof is formed by a thin plate of bone called the tegmen tympani, and the floor is also very thin. Or what sits underneath that is the internal jugular vein. What's important with the tympanic cavity is that it's connected to various neighboring anatomical structuring spaces, right? So we have two main things. So we have anterior medially, we have our eustachian tube, also known as the auditory tube. This facilitates equalization of pressure within the tympanic cavity and also the ambient pressure, so the air pressure around us. Posteriorly, in the epitympanic recess, we have what we call mastoid air cells. So these are cells within the epitympanic recess, and they are a bony structure that have air-filled spaces in between them. They act as what we call a buffer system, right? So the main way of equalization of pressure is the eustachian tube. But these cells, let's say the eustachian tube isn't functioning as we'd want it to, and the pressure in the middle ear becomes really low, these cells can release air, equalizing that pressure again. Okay. The eustachian tube, again, like I mentioned, is a means of equalizing the pressure between the ambient pressure and the middle ear. So it's a cartilaginous and bony tube, and it connects to the nasopharynx. It extends from the anterior wall of the middle ear in an anterior medio-inferior direction. Okay, opening onto the lateral wall of the nasopharynx. So because it connects two structures, there's always a risk of a pathway to share infection. So what we can see is sometimes when we can get an infection of the middle ear, otitis media, what's usually preceded this is a URTI, an upper respiratory tract infection. So yeah, we'll get onto that a bit later, but that's some clinical context there for you. The tube is very short. It's very short, but particularly short in children, and it's quite straight as well. So therefore, if they have an upper respiratory tract infection, they are more likely to get middle ear infections. And just a couple of other key bits of anatomy. There are some muscles that I want you to be aware of. The muscles are there to provide a protective function in the middle ear. Let's say there's a really loud bang, right? That produces a lot of sound waves, and that can go through the ear, causing a lot of vibration and causing a lot of damage. So we have something inbuilt called an acoustic reflex. Essentially what happens is when we perceive a really loud sound, these muscles contract preventing the amount of vibration that can happen, which should hopefully limit any damage. So what are the two muscles? We have our tensor tympani, which is the one that originates from the external acoustic meatus, and that attaches onto the handle of the malleus. And when that contracts, it pulls it medially. Okay. That's innervated by the tympani nerve, which is a branch of the mandibular nerve, which in itself is the division of the trigeminal. Okay. The other muscle that we have is what we call the stapedius. So we've got three little ossicles here. Stapes is one of them. So this muscle attaches to the stapes, and again, loud sound that contracts and prevents vibration, and that's innervated by the facial nerve. So the anatomy of the inner ear. So we've moved in more medially now. So the inner ear is the innermost part of the ear, of course, and it contains our vestibulocochlear organs. Serves two main functions. So that's to convert mechanical signals into electrical signals. So the vibration that travels along the tympanic membrane and the ossicles need to be turned into an electrical signal so that our brain can perceive that. Okay, and the other thing that it's quite crucial in is detecting balance. Maintaining balance by detecting position and motion. Okay, so in terms of the anatomy can be quite difficult to understand. So we're looking at the orange bit here. It's essentially a closed system of intercommunicating membrane sacs and ducts, which lie within a complex of bony cavities. So the orange bit that we're seeing, they're the bony cavities. And I'm sorry I don't have a better image for this. So the orange bit is the bony cavities, and what lies inside of it is the membrane. What's important about this is there's different fluids that lie within each cavity. So within the bony labyrinth, we have our perilymph, then we have a layer of membrane, and then within that, we have our endolymph. And what's crucial about that is they have different charges. We won't get too much into the biochemistry of it, but I think it's just important to be aware of. In terms of the cochlea, we'll focus mainly on the cochlea today. It's made out of a few, there's some key chambers that we need to be aware of. Firstly, in terms of the general anatomy, you can see it's quite a conical shape. Imagine that this cone is coming out towards us, right? And that kind of sits on a bone called the medullus. The function of the medullus is it just acts as a bridge between, basically the cochlear nerve pierces it and it goes to various parts of the cochlea. Okay. The medullus, the part we can actually see this. There's something called the spiral lamina, which is kind of this triangle position here. So if you can see the cochlear nerve, the bone surrounding that is a spiral lamina. So that's continuous with the medullus, right? And what comes off the spiral lamina is our vestibular membrane, also known as the upper lip, and the basilar membrane, which is the lower lip here. And because of these two membranes, we've now essentially segmented the cochlea into three main channels, right? So you've got the scala vestibuli, scala tympani, and also the cochlear duct. What I want you to appreciate is if you look at the image on the left, we've got our tympanic membrane, and that transfers our vibrations through our oval window. We're now in what we call the scala vestibuli. Whilst it looks like they're two separate things, they actually connect at the apex, so they are actually a continuous space. And what happens is the vibration carries on through the scala vestibuli, around and back down through the scala tympani. And what happens is that vibrates the basilar membrane and essentially excites the organ of Corti there, which is how we can perceive sound. In terms of how that happens, we have the tectoral membrane, which doesn't move, but the basilar membrane, which does move, and our organ of Corti. Our organ of Corti in the lateral position, or the lateral part of the organ of Corti, has hair cells, followed by a duct, and then one singular hair cell. What happens is, I mentioned that there were some difference of fluids, right? Within the cochlear duct, we have our endolymph, which is very rich in potassium. Most of our body is rich in sodium and very, poor in potassium. It's opposite here in the endolymph, right? And what happens is these hair cells, once there's a vibration of the basilar membrane, it opens the cell via the stereocilia. Potassium flows into the cell, depolarizes it, and then that sends a signal along the nerve. Okay. Apologize, it's a bit tricky to understand, but unfortunately, that's medicine for you. Okay, the tympanic membrane. So coming back out now, between the external auditory meatus and the middle ear. So this is an oval, semi-transparent structure situated between these two cavities. And there are a few main parts. So we have our pars tensor. This forms the majority of the membrane. It's the main body that you can see, right? And on the outsides, it forms a fibrocartilaginous ring that we call the tympanic ring. In the superior portion, we have our pars flaccida, also known as shrapnel's membrane. It's a small triangular portion of the membrane, and it's situated superior to the lateral process of the malleus. So if you have a look here, the manubrium of the malleus, that's the lateral process. Okay, brilliant. And then there are two surfaces. We've got the lateral and medial surface. The lateral surface is concave towards the external auditory meatus, and the medial surface is convex towards the tympanic cavity. Okay, and in between that is, directly in the middle is the umbo, which is where the malleus actually attaches. In terms of actual clinical appreciation, when we shine what we call an otoscope into the ear, there's a light that reflects back, and this is the cone of light that we can see here. In order for you to be able to appreciate whether it's the right or left ear, we look at where the cone of light is situated. So if the cone of light is situated in the 5 o'clock position, so let's say, our circle is now clock face, 12, 1, 2, 3, 4, 5, this is the 5 o'clock position, that means we're looking at the right ear, okay? If it's at the 7 o'clock position, that means we're looking at the left ear. Just a couple of other things to mention as well. There's a dual blood supply to the tympanic membrane. The outer part receives it via the deep auricular artery, whilst the medial surface receives blood via the anterior and posterior tympanic arteries. And in terms of its innervation as well, there are 3 cranial nerves that innervate it. So the anterior portion is done by the auriculotemporal nerve, which is a branch of the mandibular nerve, which is CNV3. So that comes off the trigeminal nerve. Whilst the posterior part is done by the vagus nerve, and the medial surface is done by the glossopharyngeal nerve. So the reason I mentioned these is we'll hear these nerves mentioned a bit later on. So mandibular nerve, the auriculotemporal nerve. If we have some TMJ dysfunction, that inflammation can cause issues with the auriculotemporal nerve. So if we have an issue with our TMJ, we can have referred pain to the ear, okay? So if we have otalgia, it's not necessarily just to do with the ear, it's to do with the TMJ or any other cause, for example. The glossopharyngeal nerve, again, there are other causes there are other reasons as to why we can get ear pain due to the glossopharyngeal nerve, but we'll get onto that a bit later. What else is there to mention? Again, this is a physical barrier between the middle and outer ear, and so there's a role of protection here as well. Okay. And just like I said earlier, so if we look at the 7 o'clock position, that means we're looking at the left ear. Looking at the 5 o'clock, if we see the cone of light at the 5 o'clock position, that means we are looking into the right ear. Okay. In terms of the innervation to the ear, this is done by the vestibulocochlear nerve. So we mentioned earlier that the the inner ear is split into two main organs: the vestibular organ, or the vestibular apparatus, and the cochlear apparatus. So the vestibular nerve is the eighth cranial nerve, and it consists of two main divisions: the vestibular and the cochlear nerve. The vestibular nerve, like I said earlier, goes specifically and only to the vestibular apparatus. So it conveys information from the vestibular apparatus to the nuclei, to the vestibular nuclei in the pons and brainstem. That allows us to maintain balance, spatial orientation, and coordination. In terms of the cochlear nerve, this goes along the auditory pathway, conveying auditory information from the cochlea to the cochlear nuclei in the brainstem, and that allows us to, or that enables us to have a sense of hearing. In terms of the path that it goes through, it can be quite tricky to get a grasp on, so I'll try and go slowly. So it originates from the medulla oblongata, if you look at the picture on the left, specifically at the pontomedullary junction. So this is where the pons and the medulla meet. It then travels laterally, passing through the internal acoustic meatus, which is what you can see in the middle image, which is a canal within the petrous part of the temporal bone, and that it runs alongside the facial nerve here. And then as soon as it goes into the internal auditory meatus, it splits into its two main branches. So we have our cochlear nerve and our vestibular nerve. The cochlear nerve specifically travels from the internal acoustic meatus to the cochlea, goes through our modulus and then to the cochlear organ. It innervates the spiral ganglion, and that's again purely responsible for transmitting the auditory information from the hair cells to the cochlea to the brain. It goes back to the cochlear nuclei in the brainstem, which then goes to the auditory cortex in the temporal lobe of the brain. The vestibular nerve, again, that travels through the internal auditory meatus to the vestibular apparatus. That includes the semicircular canals, utricle and saccule. That innervates the vestibular ganglion and carries information from the sensory receptors, so the hair cells, and the otolithic organs, which are within the utricle and saccule. And it's again, like we mentioned earlier, it's important for maintaining balance and spatial orientation. Yeah, I don't want to get too much into detail for this because it can get quite complex. I think it's also important to mention that in terms of the afferents, the accents of the cochlear nerve synapse in the cochlear nuclei, which is in the medulla oblongata. From there, the information is relayed to higher auditory pathways, so the superior olivary complex and also the inferior colliculus. And then again, that goes to the temporal lobe, which is involved in sound processing. The vestibular nerve synapses in the vestibular nuclei, which is located in the pons and medulla oblongata. These outputs are then sent to our cerebellum, because cerebellum's crucial for our balance coordination. The oculomotor nuclei, which is for eye movement, and the spinal cord, because that's involved with spinal control and reflexes. Okay. In terms of the external ear vasculature, it's all done by the external carotid artery. So we have our posticular auricular artery, which just goes posterior to the auricle. We have our superficial temporal artery, which is just anterior of the auricle. We have our occipital and also our maxillary, which is quite deep there. So I'm not sure if you can see that. In terms of venous drainage, it follows the arteries as listed above. Just a few more things now in terms of anatomy. It's quite important that we appreciate the facial nerve and trigeminal nerve anatomy. This can be a lot, but what I want you to appreciate specifically with the facial nerve is what key things it goes through. Okay, so in terms of the course, we mainly divide it in as intracranial, so that's through the cranial cavity and through the cranium itself, and extracranial, so that's the course of the nerve as it goes outside the cranium, through the face and through the neck. So we'll start off intracranially. So it arises from the pons, which is an area of the brainstem, and it begins as two roots. We have our motor root, which is that big root there, and our small sensory root. This sensory root is sometimes called the intermediate nerve. So the two roots, they travel separately through the internal acoustic meatus. Okay, so by separately I mean they're not one nerve yet; they're still two separate things, which is about a centimeter long. And here they're in very close proximity to the inner ear, which we'll revisit later. So still within the temporal bone, the roots leave the internal acoustic meatus and they enter into the facial canal. Okay, so we haven't left the temporal bone yet. We're still in the temporal bone. We just left the internal acoustic meatus and created a new canal called the facial canal. Within the facial canal, this is where three important events occur, right? So firstly, the nerves fuse together. So you can kind of see that here. So now we're officially the facial nerve. The nerve then forms the genicular ganglion, which is just a bunch of nerve cell bodies. And then it gives rise to a few important nerves. So remember, this is all within the bone. So we have our greater petrosal nerve, which are essentially just parasympathetic fibers to mucus glands and the lacrimal glands. Then we have the nerve to the stapedius, which is what we mentioned earlier, and then the chorda tympani. So this gives us some special sensory fibers to the anterior 2/3 of the tongue, which allows us to have taste sensation, and then also parasympathetic fibers to the submandibular and sublingual glands. Once it's done that, the nerve then exits the facial canal and the bone altogether, or the cranium, via the stylomastoid foramen, which is just located just posterior to the stylo process of the temporal bone. Once it's exited, it runs superiorly, so you can see that on the right-hand image there, and it gives rise to the posterior auricular nerve, which essentially just gives innervation to some of the muscles around the ear. It also gives some nerves to the digastrics and also the nerves to the styohyoid muscles. And then it continues now as the main motor root of the facial nerve. So it continues anterior and inferiorly into the parotid gland. The key thing here is that it doesn't contribute to the innervation of the parotid gland. The parotid gland is innervated purely by the glossopharyngeal nerve. Okay. Within the parotid gland, so the parotid gland just sits on the side of the face, on the side of the jaw here. It splits into 5 main branches. So we have our temporal branch, our zygomatic branch, buccal branch, the marginal mandibular, and the cervical. I'm sure there are some lovely fun mnemonics that you can come up with to remember those. Again, a bit more anatomy. I know it can be quite a lot, but I do think it is quite important. We'll be looking at the trigeminal nerve now. So this originates from, so we have, within the trigeminal nerve, we have sensory and motor nuclei that contribute to this. So in terms of the sensory, there are 3 main nuclei. So we have a mesencephalic, we have our principal sensory nucleus, and also the spinal nucleus. And we also have one motor nucleus, which extends from the midbrain to the medulla. Okay. At the level of the pons, these nuclei join, or the sensory nuclei join to form the sensory root, but the motor continues as just a motor root by itself, right? In the middle cranial fossa, they expand to form what we call the trigeminal ganglion. So remember, ganglion is just a collection of neuron cell bodies outside of this, the CNS, the central nervous system. And then the trigeminal ganglion is located in what we call the cavernous sinus, which is a depression in the temporal bone. We call this depression specifically for this ganglion the trigeminal cave. Then it gives rise to its three divisions. So we have ophthalmic, maxillary, and mandibular. We'll just refer to these as V1, V2, and V3. The motor route that we talked about earlier, that passes inferior to the sensory routes, and it runs along the floor of the trigeminal cave, but the fibers go purely to the mandibular division. So essentially what we're saying is the ophthalmic and the maxillary divisions are purely sensory, whereas mandibular has both sensory and motor portions. Okay. Next, we'll look at the muscles of facial expression. So these are done by cranial nerve 7, also known as the facial nerve. And there are 5 main branches that we talked about. The 5 main branches go to innervate specific things that are important on clinical examination. So the temporal branch does the frontalis, which is a set of 2 big muscles in the forehead, which allow for eyebrow elevation. The zygomatic does the orbicularis oculi, which allows for eye closure. The buccal branch does orbicularis oris and the buccinator or buccinator, which is mainly for cheek control. The marginal mandibular does lower lip movement, and the cervical branch does the platysma, which is just a big, thin muscle that goes around the neck. What I think is important here is if we have somebody with a specific lesion to one of these branches, we will see basically a weakness or a deficit relative or specific to that muscle that it innervates, right? So, for example, if we have a lesion with the zygomatic branch, that leads to orbicularis oculi weakness, which means that the patient can't close their eye fully. We call this legophthalmos because this predisposes patients to corneal ulcers, legophthalmos. Okay, so that's the main thing that we worry about there. If we have a lesion with the buccal branch, just one more example, if you have a lesion with the buccal branch, that can lead to difficulties with drooling and also speech difficulties as well. So those are some important things to pick up on there. So the facial nerve, generally we break it up into upper and lower motor neurons. The reasoning for this is clinically is because the lesion can present anywhere along the facial nerve, but we worry about, we need to figure out whether this is upper or motor, right? So if this is lower, the main things that we're worried about are Bell's palsy, parotid tumors, and cholesteatomas. The patient presents with ipsilateral whole face paralysis, okay? However, if it's an upper motor neuron lesion, the main thing that we're worried about is a stroke here. We'll have forehead sparing, okay? So clinically, if somebody has ipsilateral face paralysis, ask them, can you lift your forehead? If they're able to, that means they're having a stroke, most likely. If they're not able to, it's more than likely, or most likely, a lower motor neuron lesion. Again, you need to take that with a pinch of salt because, it might be a bilateral stroke. But generally, this is the reasoning. It always took me a long time to figure out why this happened. But if you look at the image on the left, so the normal image, let's say this patient presents with a stroke in the right hemisphere, so the hemisphere with the green and yellow nerves, that serves the left-hand side of the face, right? So we see that the lower portion of the face is done by yellow. That's not going to work because we have a lesion there. The upper portion of the face is done by green, so that's not going to work. But we also see that the purple branch or nerve or pathway from the left hemisphere is also innervating the forehead, right? So that's the reasoning as to why we can have forehead sparing in these cases. Next, we'll talk about muscles of mastication, which is essentially just our chewing muscles. These are done by the mandibular division of the trigeminal nerve, so CNV3. and that supplies all the motor supply to these muscles. There are four main muscles. We've got our masseter, which is the main chewing muscle. That's the big muscle that we find on the side of the face or the head, and that elevates the mandible or closes the jaw. Same thing. We've got our temporalis, which elevates and retracts the mandible, so brings the mandible backwards. And then we have our pterygoids. We have our medial and lateral. So the medial pterygoid closes the jaw and protrudes the mandible, whereas the lateral pterygoid opens the jaw and moves it from side to side. When we have a trigeminal palsy, we'll have a loss of sensation to the ophthalmic and the maxillary, but we may also have loss of motor function to our muscles of mastication. So what we'll see in a patient when they present with this is the jaw will be deviated to the side, to the weak side, i.e. The side with the lesion or the dysfunction. They'll lose the ability, or they'll lose strength for chewing, and they'll have an absent jaw jerk reflex. In terms of TMJ, so we talked a little bit about this earlier. If we have TMJ dysfunction, this can give us what's called referred pain to the ear. This is via the auriculotemporal nerve, which is a branch of CNV3, which is the mandibular branch. If you remember earlier, we said that this innervates partially the eardrum, and so if we have inflammation or something wrong with the TMJ, the pain travels along that pathway, and it can be misinterpreted as pain there. That's one reason. The other reason is the TMJ is very close to the ear canal, and so just by the nature of it being so close to the ear canal, it can again be misdiagnosed as otalgia. Okay, how you can figure out these patients have a TMJ as opposed to an ear issue is they'll have clicking of the jaw, difficulty chewing, and bruxism. Bruxism is basically like grinding, so clenching and grinding. Great. The salivary glands. So there are three main pairs of salivary glands, or three main salivary glands, I should say. So we have the parotid glands, which are the main ones. We have our submandibular and our sublingual. So parotid gland, so not main, but largest. So the parotid glands are the largest. They lie over the masseter, and they're pierced by the facial nerve. Okay, again, very important. It doesn't innervate the parotid gland, it just pierces it. The submandibular gland lies in the digastric triangle, so just underneath the jaw there, and opens at the floor of the mouth. And our sublingual glands, they're the smallest, and they're underneath the tongues. What's clinically significant about these is the relation that they have to some nerves. So like we said, facial nerve goes through the parotid. If we have an issue with our parotid gland, for example, we can get benign tumors called pleomorphic adenomas. Whilst they are benign, they can compress on the facial nerve, causing inflammation or just compressive force on the facial nerve, which can give some facial paralysis there, facial pain. Also with pleomorphic adenomas, there's a decent chance that they can become malignant. And so many people may choose to take that out. Surgically, we have to be very careful to isolate the facial nerve and to remove it very carefully, because if we injure the facial nerve, that will cause just a whole world of problems. Okay. The other important thing to mention as well is the submandibular gland is closely related to a couple of nerves. So the first one that we have is our lingual nerve. So this is a branch of the mandibular, which is a division of the trigeminal. So the lingual nerve is a branch of CNV3. And the other nerve that we worry about is the hypoglossal nerve, so cranial nerve 12. If we have an issue, cancer, maybe a tumor, or maybe we need to have surgery on the submandibular gland, there's risk to damage of these, the lingual and hypoglossal. That can cause tongue weakness and a loss of sensation. So you have to be really careful there. the neurovascular supply to the parotid gland. So like we said before, it's supplied by the glossopharyngeal nerve, which gives rise to the otic ganglion, which then sends, I think, some parasympathetic fibers off to the auriculotemporal nerve, which is a branch of the mandibular, meaning that there's kind of like a relay there. So basically, if you have an issue there, we can cause pain upstream, if you will. And as we said before, the auriculotemporal can affect the eardrum. So again, this is another reason or another means of referred ear pain. The blood supply is done by the external carotid artery, and venous drainage is done by the retromandibular vein. In terms of some of the symptoms that we can have if we damage these nerves, so first and foremost, we have facial nerve damage, which is just weakness, paralysis. We can get something called Fraze syndrome, which is quite interesting. So this is when there's misdirected autonomic fibers regenerating into sweat glands as opposed to salivary glands. So when the patient either thinks about eating or they are actually eating, instead of producing saliva, they actually start to sweat, which is really interesting. So that's Fraze syndrome, also known as gustatory sweating. Something that we can also have as well is first bite syndrome. So this is a syndrome that is characterized by severe, sharp pain in the parotid region during the first few bites of a meal, and it usually improves as the eating continues. It often results as a parotoidectomy, or not often results, but when we see it, it's usually because of a parotoidectomy or other head and neck surgeries. It's due to damage to the sympathetic innervation, which leads to unopposed parasympathetic stimulation to the salivary myoepithelial cells, which results in really painful, exaggerated salivary contractions. This is patients will particularly raise this, or they'll say this worse when they're eating, particularly sour or flavorful foods. Yeah. And like we said before, numbness, and then we can, other classic things are seromas and hematomas there. So this is just kind of like a bit of a summary, something for you guys to take away and learn. Why does referred pain occur? It's because the ear shares sensory innervation with multiple cranial and cervical nerves. So pain from other head and neck structures can be misinterpreted as ear pain due to overlapping nerve pathways. So we talked a lot about the auriculotemporal nerve. Facial nerve, again, another big one. Something interesting about Arnold's nerve. So Arnold's nerve is a branch of the vagus nerve. I think it comes off of the recurrent laryngeal. I'm not entirely sure, so don't quote me on that, but comes definitely off of the vagus nerve. And what can happen is if we have throat cancers, so laryngeal cancers or oropharyngeal cancers, this can compress on the nerve, and this goes all the way up into the ear, the external auditory canal and the concha. So we can get pain basically downstream of that, and that again can be misinterpreted as ear pain. Okay, so let's go to some of the causes for ear pain. So we have primary and secondary causes. Primary causes basically mean, actually, should we do a poll? I've realized there are some polls actually that I can release. So we are quite far into the talk now, but I can release them for you now and you can give them a go. Let's try this one. Can you guys see that? Nice. 4 for eustachian tube. Nice. 1 for cochlea. Just leave it a few moments. Okay, so majority of you went for eustachian tube, which is correct. Why is it not the other options? So like we said before, the eustachian tube is important for equalizing the pressure. The cochlea, that's the organ responsible for hearing and converting sound vibrations into signals, but doesn't have any roles within pressure regulation. But well done, everybody, regardless. Let's do another one. Why not? So which nerve is responsible for referred ear pain in the temporal mandibular joint dysfunction? It's a difficult one, guys. So 1 for auriculotemporal, 1 for vestibulocochlear. One for facial nerve. Two for facial nerve. If I click answer, does it show? Okay, the majority of you are going for auriculotemporal nerve. Yes, so it is the auriculotemporal nerve. Yeah, I can't really give you a justification as to why it's not the other ones. But that is a difficult question, so well done to those of you who got it. Okay, yeah, let's continue. There are a few more polls that we can do later on. Okay, causes of ear pain can be primary or secondary. So primary means it's within the issues within the actual ear itself. Secondary means it's more referred ear pain. So the main ones that we'll talk about are otitis externa, media, mastoiditis, and cholesteatoma. So what is otitis externa? It's often called swimmer's ear, and it's characterized by inflammation of the external ear canal, often caused by infection. Okay, there are a few main culprits that we have to be worried about. So bacterial culprits are Pseudomonas. I'm not even going to try and say that. And the next one is Staph aureus. We can also get some fungal causes, so Aspergillus and Candida. I apologize if I've said those wrong. However, fungal is usually seen in immunocompromised patients, so those that are on immunosuppressant drugs, diabetics, for example. Oh no, diabetics aren't an example of those on immunosuppressant drugs, but they're also immunocompromised. Okay, in terms of risk factors, it's called swimmer's ear, so you'd be correct to assume that swimming is a risk factor. Excessive ear can cause it due to inflammation, mechanical inflammation, but also removal of the cerumen. Hearing aids, because something is indwelling within the ear, so that can always cause an infection. Eczema due to localized inflammation, and diabetes for the reasons we mentioned earlier. What can happen is not necessarily a complication, but more of a natural progression, is this can develop into something that we call necrotizing otitis externa. I think in other textbooks, other places called malignant otitis externa, such as on PassMed, but now we call it necrotizing otitis externa. This requires urgent management because essentially what this is a spread of the infection to the skull base, causing skull base osteomyelitis. Rare condition, but it's very serious. And when we see it, the individual is usually within that immunosuppressed category. Okay. How do we treat it? So, in most cases, we can use topical antibiotics. We can also use steroids as well. So what we'd use for that is ciprofloxacin, and can also use dexamethasone topically as well. But we care about the surgical interventions. When do we need these? So if we have necrotizing OE, we have to surgically manage this if it's severe enough. So IV antibiotics to cover for the pseudomodal infections. We need to surgically debride it, which means removing all of the tissue that is necrosed. And if it's extended far enough into the temporal bone, we need to do a mastoidectomy. In terms of recurrent or obstructive otitis externa, what can happen is, due to so many cycles of inflammation and resolution, the fibrosis leads to canal stenosis, which can lead to trouble hearing, and is kind of acts, I think, like a positive cycle, right? So what we need to do is basically widen that canal up, and we do a canaloplasty, which is, like I said, a widening that ear canal. And then if in fungal cases, they can have some debris there, we can just suck that out using some microsuction. So here are just some images. So on the left is what we'll see externally. On the right, that's kind of like a severe case of canal stenosis. So as you can see, sound is not going to get through that. The patient's really going to struggle to hear. Otitis media. So this is a middle ear infection, usually preceded by URTI, because remember what we said, the eustachian tube goes from the nasopharynx to the middle ear. So the bacteria that cause this usually are ones that are quite well known for causing URTIs, right? So things like strep pneumoniae, H flu, and also Maroxella, more of a atypical bacterial infection. The patient will present to you with otalgia or ear pain, fever, hearing loss, and a bulging tympanic membrane, because there's so much stuff within the middle ear that is pushing out the tympanic membrane. What can happen is, again, like as a natural progression, if this doesn't resolve itself, the pressure will build up and build up and build up, and it can perforate the tympanic membrane. What that means is the patient will explain that they had a sudden pain relief with otorrhea, so they had some discharge from the ear as well. What this essentially shows us is that the main reason for pain is the pressure from within the ear. If we don't do anything about it, it can become complicated, become mastoiditis, which is an infection of those mastoid air cells. We get a cranial nerve 7 palsy, facial nerve palsy, because, again, like we mentioned before, that lies so close to the ear. We can also get, the classic things like an abscess. And then the one that we're really worried about is meningitis, okay? We're always worried about ear infections progressing to becoming meningitis. Otitis media with effusion. This is commonly known as glute ear, so you may have heard it as glute ear. This is basically a problem where the eustachian tube hasn't had the ability, or isn't working correctly, and so the pressure between the middle ear and the ambient surrounding pressure is basically, it isn't working, right? So what happens is the pressure drops from within the eustachian tube. We've now kind of got like a closed loop, right? Whereas if you think about it, the middle ear kind of has a way out into the open world. Now it's completely closed off, okay? So we have a negative pressure that develops inside the middle ear. Because the pressure is so low, it draws out transidate from the mucosa. So fluid builds up, and unfortunately, this is just a ripe, great place for pathogens to replicate and cause an infection. how we will identify these patients is we'll look inside the ear. The eardrum will be inverted and the fluid will be visible. And I think in most cases you can see kind of like a bubbly, it looks bubbly, but I have some photos to show you after as well. So how can we deal with OM? First line in uncomplicated cases, we can do supportive care, analgesia, and antibiotics if it's severe or prolonged. When is surgery needed? So if we have persistent effusion, so persistent glue air for greater than 3 months, we can do what we call a grommet insertion, which is basically just putting a tube in between the tympanic membrane, in the tympanic membrane, which acts as like, I guess, like a eustachian tube and allows pressure to go from the ambient pressure into the ear, relieving that pressure. What can happen is if we leave it for so long, just normal acute otitis media, we get mastoiditis and intracranial complications such as meningitis, things like that. So if they have more than three episodes within 6 months or more than 4 within 12 months, we'll do a mastoidectomy. But we can also do a mastoidectomy, or should also do a mastoidectomy, if a mastoid abscess forms. Again, because we're really trying to avoid basically a meningitic picture. And then for effusion, if it's still continuing, we put a grommet in, and we can also do an adenoidectomy. So adenoids, they sit actually quite close to the eustachian tube. There's a couple of reasons as to why we do this. So firstly, if you get recurrent infections, the adenoids grow and they can physically compress on the eustachian tube, blocking it off, and then obviously not allowing the pressure to go into the middle ear. What can also happen is the adenoids act as, I guess, a harbor for bacteria, and so due to proximity, they can now travel into the internal, also the middle ear, causing some issues there. So if we have a look at the picture on the left, this is what we'll see on otitis media. So quite angry, but we have a bulging picture. So we can see that the umbo is depressed, and then we have bulging around that. OME, so otitis media with effusion, the tympanic membrane is sucked in, and we can tell that because like the bones are protruding a bit here. And we can also tell as well, because I think because the cone of light is closer to the umbo, that might not be correct. And we can also see the effusion behind the tympanic membrane. It's so thin that you can see that. And then it's quite bubbly as well, which I think is quite a classic sign. In terms of management, so on the left is a grommet insertion. So we've just put basically a tube that allows equalization of pressure between the middle ear and the external acoustic meatus. Mastoidectomy, so the surgeon has just gone behind the ear here, cut through the cranium and into the mastoid, and we can see all of those air-filled pockets there. Mastoiditis, so like we said before, this can be as a result of otitis media. Due to the porous nature, because there's so much air there, there's quite a suitable site for pathogenic replication. If it gets infected, it can spread to the middle cranial fossa, causing, like we said, meningitis. If we have this, we must drain the pus from the air cells because we worry that it's going to spread again, like we said. And we need to make sure that we don't damage the facial nerve. That's, I guess, one of the main complications that we're worried about here, or main surgical complications here. How can we treat mastoiditis? So it requires very prompt and effective treatment because, again, we can't progress to those serious complications. We'll put them on some broad IV antibiotics, usually ceftriaxone. If that doesn't work, we're going to have to move on to surgical management. So that includes a mastoidectomy, just removing the mastoid air cells and debridement of the infected bone tissue. Maryngotomy. So if there's pus that's now traveled from the mastoid cells into the middle ear, we can just make a small incision into the eardrum, allows pus drainage. And then if there's damage to the eardrum, we can just do a tympanoplasty, which allows, which just repairs it, essentially. And then chronic otitis media and cholesteatoma. So chronic otitis media basically leads to persistent tympanic membrane perforation. And then cholesteatoma, these are both chronic conditions. Cholesteatoma is when abnormal keratizing squamous epithelium grows in the middle ear, leading to the destruction of those small bones within the middle ear and the surrounding structures. So we'll get persistent otorrhea, conductive hearing loss, and vertigo. And then again, very similar to the previous complications, so brain abscess, meningitis, and facial nerve palsy. How do we manage these? Cholesteatoma always is surgical, and we do a mastoidectomy to remove the disease. There's a couple of ways we can do this. We could do a canal. So let's say it's a patient's first time. We can do something called a canal wall up. So that preserves the canal, and it's better for cosmesis. But we run the risk that the cholesteatoma can occur again. Canal wall down removes the canal. There's lower reoccurrence, but there's a lifelong ear care. And in terms of complications, hearing loss, dizziness, and again, facial nerve palsy. For persistent tympanic main perforation, so in cases of chronic otitis media, we just use a tympanoplasty, which is a graft to repair. Almost at the end now, guys. So auricular hematoma. So this is caused by, this is like cauliflower ear. I'm sure you guys have heard of it. And it's caused by blunt trauma, often in contact sports. So, you'll see it classically for, the Dagestanis, MMA, also seen in rugby, boxing as well. So blood collects between the auricular cartilage and the perichondrium. If we leave it for so long, it leads to cartilage necrosis and permanent deformity. And it presents as a tender, fluctuant swelling of the ear because it's fluid, it's blood. What we need to do is instantly drain it, or as soon as you can, drain it and compress it to prevent the cartilage necrosis and to prevent anything else from getting underneath and expanding that out. In chronic cases, surgical incision. So with the immediate drainage, we just use a needle. Chronic cases, we will surgically excise it, drain it, and then use quilting sutures, which basically just holds the perichondrium to the cartilage using sutures. If we've left it long enough that we got fibrosis and cartilage damage, then we need to repair that as well. Let's see if there's a poll. Or release this poll. These are some difficult questions, so don't worry if you don't get them. Okay, majority of you are going with painless otorrhea. Some say tympanic membrane perforation, painless otorrhea. Okay, painless otorrhea is correct. Let's justify why it's not the other options. So conductive hearing loss, we do find this in cholesteatoma, but it also occurs in chronic otitis media, so it's not very specific. but none of you actually went for that, so fine. Tympanic membrane perforation, seen in both cholesteatoma and chronic otitis, but again, doesn't distinguish between both of them. Recurrent ear infections, seen in many pathologies, including chronic otitis media, but it's not unique to cholesteatoma. But yeah, very well done, guys. Let's do a couple other ones. Again, these are difficult, so don't worry. So, which of the following patients should be referred urgently to ENT? Okay, unilateral pain, hoarseness. Yeah, so majority of you are going for the pain, the unilateral pain and hoarseness, which I would. Oh, should we just wait for a couple more? So some are saying recurrent otitis externa. Okay, we'll leave it there. So the unilateral ear pain and hoarseness, that's the one that we're worried about, right? Because that's a red flag for head and neck cancer. Okay. I think we will actually come on to that a bit later. So you guys answered it without even being taught it. So that's my bad. I shouldn't have released that. The incorrect options, let's justify why it isn't those. So the 30-year-old with recurrent otitis externa after swimming, this is probably just due to, it's just a chronic irritation. We can just manage that with ear drops and lifestyle changes. It's not urgent. Okay. We're in the second one, we're worried about that it's cancer. Okay. Yeah, well done. Let's check. I have one more poll question. We'll save it for the end. Okay. So secondary causes. Secondary causes means that the issue lies outside of the ear from elsewhere, but it's causing either referred pain or local pain towards the ear. Okay. So TMJ dysfunction, this is a common cause of ear pain. Patients usually have clicking, limited by mouth opening, and pain exacerbated by chewing. We also have a bruxism, which is, like we said, grinding, clenching of the jaw. Malocclusion, meaning that the teeth don't come together properly as we'd want them to. Sorry, these are risk factors for TMJ dysfunction, and also trauma as well. Yeah, that's it really. How can we manage this? Bite splint. So like we said, malocclusion is a risk factor for getting TMJ dysfunction. So I think your dentist just put them on as like blocks, and they can push your jaw into the correct place when you bite down. Physiotherapy and also non-steroidals. Surgical options are arthrocentesis, which is basically just flushing out the joint, and arthroscopy to remove any adhesions from within the joint. And in really rare cases, we can do a full joint replace of the TMJ. Parotid tumors, this is referred otalgia via cranial nerve 7, like we said, so the facial nerve. And like we said, the most common thing that we're worried about is pleomorphic adenoma. It is benign, but it can become malignant. The patients will, and this again is just a compressive force or local inflammation, or I'm not sure if it actually, can travel into the nerve whilst it's benign, but I'm sure when it's malignant, it can. And it's painless. It's a painless mass just out on the side. It's asymmetrical. And again, like we said, we get the referred ear pain. Indications for the removal are if we suspect it's going to become malignant, if if there's a large tumor, and if there's a cosmetic concern as well. We can either take out the more superficial portion of it, which is the most common issue, or we can do the total parotoidectomy. But again, this is where we have the risk or the higher risk of affecting the facial nerve. And then again, the similar risk as well. So facial nerve damage leading to paralysis, etc. of the face, and then Frey syndrome, which is that gustatory sweating. Looking now at laryngeal and oropharyngeal tumors, we're worried about a nerve called Arnold's nerve, which comes off of the vagus nerve. This goes and innervates the ear, but due to its path, if we have a mass within the larynx or surrounding oropharynx, this can compress it and cause pain. So we get persistent unilateral ear pain, hoarseness, dysphagia, and weight loss. This was in the this is what we were worried about in the question as well. Okay, so my apologies, I released that a bit early. But yeah, persistent unilateral pain, hoarseness, dysphagia, weight loss. Red flags for oropharyngeal or laryngeal cancers. The pathophysiology is compressing or causing damage or any other mechanism to Arnold's nerve, which is a branch of cranial nerve 10, vagus nerve. How can we manage this? We resect it if we can. The procedures that we can do are laryngectomy, so removing the larynx, neck dissection to remove any involved lymph nodes, and tracheostomy if there's an airway obstruction that we're worried about. Trigeminal neuralgia. So this is caused by irritation or compression of the trigeminal nerve, which is responsible for the sensations in the face, but also some of the motor portion of the of chewing, basically. The compression usually happens due to a blood vessel pressing on the nerve, or the other reason is due to multiple sclerosis. So the hallmark of this condition is sharp stabbing pain that typically occurs on one side of the face. It can be triggered by, basically by nothing, right? Very simple things like brushing your teeth, chewing, or even wind on the face that can cause an attack. The pain often radiates to the ear, jaw, or cheek, making it feel like the pain is coming from the ear. Okay. Causes, like we said, are compression, vascular compression, where the artery or the vein presses on the nerve, or demyelination. And of course, the main thing that we're thinking there is multiple sclerosis. How can we treat this? We use a lot of these. So carbamazepine, which is a anticonvulsant, and also gabapentin as well. These are typically used to relieve the pain. If this doesn't work, we're going to have to start doing some microvascular decompression or rhizotomy, which is basically where you kill a nerve that's causing pain. So there's quite a last line option there. And then finally, we're talking about the glossopharyngeal neuralgia. This again results in compression of the glossopharyngeal nerve. The glossopharyngeal nerve is responsible for sensation in the throat, tonsils, and the ear as well. So the condition again is usually caused by compression of the nerve. Sometimes blood vessels compressing it, tumors, infections, and any other condition. The patient will present with pain of where it innervates, right? So severe and sharp pain that occurs in the ear, throat, or the base of the tongue, and it's triggered slightly differently compared to trigeminal. It's usually done by swallowing, talking, or coughing. And while it's intense, the episodes are usually brief. So in trigeminal, it can be quite prolonged, but these are usually brief. Treatment, again, is carbamazepine, or we can use baclofen to control the pain. And again, if this doesn't work, we can do microvascular decompression or a nerve block. The reason it causes ear pain is because glossopharyngeal has nerves that supply the ear. So we talked about the tympanic membrane. Part of it is innervated by the glossopharyngeal. As such, we will have referred pain from there. And that's it. Thank you very much. I think we have one final poll. Let's do the final poll, and then you guys can go.
Thank you so much, Luckman. That was an incredible talk. I have posted, just do this now, just pasting the feedback form and in the chat. Our next session will be on ENT tomorrow as well, same time, and we would love for you to join us again. Once again, thank you so much for such an incredible talk, and I hope you guys learnt a lot about the anatomy and the clinically relevant aspects. We'll be posting Luckman's SBAs onto our socials for additional practice, so keep an eye out for them. And don't forget about the website, where you can find a resource bank with lots of materials, not just for this session, but for all of our other sessions, which includes summaries that our tutors have kindly provided and a question bank featuring extra questions that aren't available on our social media. So to access that, just create a free account on our learning portal. And we hope you found today's session valuable and engaging, and thank you so much once again for joining us. And we're looking forward to seeing you tomorrow at our next session.
Thank you. Sorry, just to hop back in there, the answer is a necrotizing otitis externa, and there are some justifications as to why. So yes, thank you very much.